Hello and welcome to another episode of Bridging the Gap. This is the series in which we aim to facilitate teaching sessions that cover a wide variety of topics and specialities that will ultimately help to inform our practice when out in the clinical areas. Today we're delving into the world of haematology, and I am pleased to introduce today's guest, who is Cat Birch, a CAR-T clinical nurse specialist.
Thank you, Sabrina. So yes, I'm Catherine, otherwise known as Cat. I work within the haematology team at Nottingham. I'm the CAR-T CNS, so I support staff with training around CAR-T, but mainly I'm the key worker for patients that are receiving CAR-T and working them up for treatment. So I'll tell you about the pathway today, and also we'll go into more detail on the associated side effects and how we care for these patients on the wards.
So presumably, Cat, CAR-T is what you find most intriguing and exciting in the world of haematology at the moment. But I just wanted to know why. What about CAR-T makes it so special for you?
With it being still a fairly new treatment, so if we're looking throughout the UK, it's probably been available on the NHS since around 2018, but various trusts have become accredited over the years. We've been accredited for the last year. So with it being a new treatment, it's very exciting that we can finally offer patients a new treatment that could potentially put them into a long remission. And these are patients that are accessing third line treatments mainly. So patients that potentially wouldn't have any other option before CAR-T and could have gone down the palliation route. So it's really exciting that patients have this second chance.
Yeah, like a lifeline.
Yeah.
Okay, perfect. Well, I'll hand over to you now to begin your presentation. Thank you so much.
Firstly, we're going to look at what is CAR-T therapy. So CAR-T stands for Chimeric Antigen Receptor T-Cell therapy. It is, as we've said, a fairly new cancer treatment. It uses the patient's own immune system to target and destroy the cancer cells. It's genetically modified T cells that bind to specific proteins on the surface of the cancer cell, and it is a type of immunotherapy. It's also known as a living drug because we're using the patient's own T cells. It's customised to each patient, so it's a form of personalised care, and it involves introducing a new gene into the DNA, which is known as the chimeric antigen receptor. So this gene helps T cells to target and destroy the cancer cells. So we're going to cover the role of the T cells. So the T cells are a part of the immune system that focuses on specific foreign particles. So they have the role of directly attacking infected cells, and they produce cytokines, which we will talk a little bit more about later on when we're looking at the side effects. During infancy, the naive T cells are crucial for developing immunity towards common pathogens, and memory T cells are established and they're maintained into adulthood. So the T cells predominantly maintain homeostasis, and they focus in on and surveillance for cancer cells. So how does CAR-T therapy work? So the CARs are composed of antibody fragments, and this allows them to recognise antigens that are present on the cancer cells. So in this case, CD19 antigen is expressed on most B-cell malignancies, so it's a fantastic target to use. Patients who can access CAR-T include patients with various forms of relapsed and refractory lymphomas. So this can include follicular lymphoma, mediastinal lymphoma, and diffuse large B-cell lymphoma, and also B-cell acute lymphoblastic leukemia. Patients with diffuse large B-cell lymphoma, if they have had a relapse within 12 months of first-line treatment or have been refractory to first-line treatment, they can actually access CAR-T on a second-line basis. However, for all the other disease groups, this is a third-line treatment. So next we're going to look at the patient pathway, just so that you can understand what the patient goes through during the workup to CAR-T. So the patient will be presented at our lymphoma or ALL MDT to discuss eligibility for CAR-T. They'll then go to the National CAR-T panel, which basically it's quite a strict criteria they use to ensure that the right patients are accessing CAR-T, to allow patients to get the funding for the CAR-T treatment. So once we've had that approval, the workup will begin, or sometimes, because it is a fast-paced pathway, I'll already be putting measures in place while we're awaiting that approval. So we'll assess the patient's veins. If the patient's veins aren't quite what we need them to be, the patient will have a Hickman line for apheresis, so they'll have their T cells collected by Hickman line. If they've got nice juicy veins, we can collect peripherally. However, if we're collecting peripherally, the patient will still need a PICC line closer to the admission date, just so we've got a good form of access, because we're going to be taking daily bloods, and we may need to treat these side effects if side effects do arise. So the patient will have their T cells collected on haematology day case. This is a day procedure. It typically takes around 4 to 5 hours, and the patient, as long as they're feeling well, they can go home. The same day, depending on the manufacturing company, because there's various manufacturing companies that provide CAR-T. So one of the manufacturing companies will have a courier that comes to collect the cells from our day case unit. However, there's another manufacturing company that will collect from our stem cell lab. So some logistical things to consider. So the patient's cells will be collected. They'll then go to the manufacturing company's labs to be reprogrammed and be made into CAR-T. They were left to proliferate and expand in the labs, and this can take, it says 4 to 5 weeks, but typically it's around 3 to 4 weeks now, as we've improved in the world of CAR-T. The labs will do quality checks as well to ensure that we've got good quality CAR-T cells and that they're happy for these to be infused back to the patient. Once we've been given the go-ahead, we'll agree on a date for the cells to be returned to our stem cell lab here at Nottingham. So once I know the patient's the delivery date that we'll get the cells back, I'll coordinate the patient coming back to hospital to be admitted for CAR-T. The patient, during the time that they're waiting for CAR-T, we'll talk more about it, but they'll have a treatment to hold their disease and keep it stable. When they're admitted for CAR-T, they'll have what we call conditioning or lymphodepleting chemotherapy to deplete their own T cells down, and then they'll have their CAR-T cells administered. And then the monitoring begins, which we'll go into a bit more detail on. So bridging treatment. So it's exactly what it says on the tin, really. It's an anti-cancer therapy that patients receive between the collecting of the T cells and the lymphodepleting chemotherapy. It can include steroids, chemotherapy, targeted therapies, and radiotherapy. The purpose of bridging therapy is to prevent rapid disease progression prior to CAR-T infusion. So the CAR-T treatment, it can be compromised if patients have poor disease control. If patients are going through CAR-T therapy with a high disease burden, they're more likely to have the worsening side effects. And also patients with greater disease burden, the CAR-T cells can become exhausted if there's more disease to fight, which could result in the cancer not completely going away or relapse. Not every patient will require bridging treatment, but the majority do. So we're going to look at the inpatient stay next. So we typically admit patients on day -6. We tend to infuse CAR-T cells on a Monday. This is the infusion day. However, due to capacity and various other reasons, sometimes the days can change. If we're going by the typical day of infusion on a Monday, we'd admit the patient the Tuesday prior. The patient would then start lymphodepleting chemotherapy, including fludarabine and cyclophosphamide, on day -5, so on the Wednesday, and this would be for 3 days. So fairly quick chemotherapies, half an hour bags, on the Wednesday, the Thursday, the Friday. They'll have rest days over the weekend, but the patient still needs to remain as an inpatient. And then day 0, the Monday, would be the CAR-T infusion day. So on the Monday morning, one of the senior registrars or the consultant covering the wards would review the patient to ensure that they're still happy to proceed with the infusion on that day. If delays occur, this may be that the patient's developed an infection and we're wanting the patient to get over the infection before the patient goes through CAR-T. We still have a 2-week window after the patient has had the lymphodepleting chemotherapy to give the CAR-T cells. If we go over the 2-week window, the patient will require more lymphodepleting chemotherapy to dampen down their circulating T cells. So patients can be discharged from day 11. Sometimes, if the patient's been quite well, we can go as early as day 10 if side effects have subsided and the patient's well enough. It's also important to note that approximately 20% of patients can be transferred to critical care due to the severity of the side effects. I'll just mention with the follow-up as well, these patients have quite an intense follow-up once they've been discharged. So if you've got a patient that's had minimal side effects, have recovered fairly well, and they can be discharged around the 2-week time frame, for the next 2 weeks up until the 4-week window, they'll have close follow-up. So they'll have 3 face-to-face clinic appointments. They may even have myself ringing them on the days that they're not seeing anybody to ensure that everything is still okay. And these patients need to have what we call a designated CAR-T carer with them because of the associated risks. In this case, the ICANS, which we will talk about. So somebody that could be a family friend, a relative, somebody who understands the side effects and can basically pick up the phone and call for advice if they need to. So precautions to bear in mind for CAR-T. We always follow the sepsis guidelines for fevers. So patients that are presenting with one of the side effects, which is cytokine release syndrome, which I'll tell you all about in just a moment, the first signs of cytokine release syndrome can be a temperature. It can mimic sepsis. So even if we're fairly confident that the patient has CRS, cytokine release syndrome, we need to cover the patient for sepsis, and they will likely be started on antibiotic cover as well. Also, these patients need to have prophylactic antimicrobials commenced prior to their lymphodepleting chemo, and this needs to continue for a minimum of a year post-CAR-T. This will include cotrimoxazole and acyclovir. Also, antifungal prophylaxis, so either fluconazole or posaconazole, depending on the prior lines of treatment and the patient's risk, until the patient's no longer neutropenic. We may be giving the patient allopurinol as precaution for tumor-lysis, and also these patients will be started on Keppra as standard prior to their CAR-T return. So 500 milligrams BD, it's as a precaution related to the ICANS because the neurotoxicity can pose a risk of seizures. So every patient will be started on Keppra. We avoid GCSF use for the first 21 days after infusion, as this could potentially worsen the side effects. However, patients who are deemed a high risk of hematological toxicities can be started on GCSF from day +2. So there's a fairly new assessment tool that the hematology team use when the patient's been admitted called the CAR Hematotox score that uses the patient's neutrophil count, the hemoglobin, the ferritin, platelets to assess the patient's risk. If the patient's scoring 2 or more, they'll be deemed a high risk and be started on GCSF from 2 days post-infusion. We also avoid steroids as pre-medications for these patients. So when we're infusing the cells, patients will have pre-medications including oral paracetamol and IV chlorphenamine. This is to do with the preservative that the CAR T cells have been frozen in to keep them viable and healthy for use, basically. However, we don't use steroids because these can ultimately damage the CAR T cells. Steroids is one of the main treatments for CRS and ICANS, so we do have to balance this risk depending on how the patient presents. So these patients also, it's important to note, can only ever receive irradiated blood products once they, we list them for irradiated blood from a week prior to their apheresis, and then it's indefinitely. And this is related to that the patient is having fludarabine as their conditioning chemotherapy. So there's no cut-off. It will be indefinite that they'll have irradiated blood. And also patients are advised no driving for 8 weeks post-CAR T because of the late onset of ICANS. Although it's a low risk, there's still a risk there. Patient monitoring. On the day the patient has their CAR T cells back, they'll have pre-observations. We'll also do baseline CRS and ICANS assessment. The cells do get administered very quickly, so we aim to have them administered within half an hour. However, depending on the patient's line, it could be 10-15 minutes and the cells have been infused. So if we can do a mid set of obs and then on completion, that is what we'd aim to do. And then once the cells have been infused, every 15 minutes for the first hour, and then hourly for 2 hours, and then routinely. These patients need to be on strict fluid balancers and have daily weights. We have noticed with these patients that the majority will get referred to dietitians, whether it's because the lymphodepletion has caused some nausea and sickness that's had a lasting effect, or whether it's the hospital stay and it's had a knock-on effect on the patient. We've noticed some weight loss. We want these patients to be as fit as they possibly can going through CAR T because it is quite an intense pathway. It's also important to note with these patients going through CAR T, when they're referred, their performance status needs to be 0 to 1. It can, however, be up to a 2 when the cells are being infused back. So we also do daily bloods on these patients. As you can see on the screen, these are the routine CAR T bloods that we take, along with weekly CMV and EBV monitoring. These patients, as they will be immunocompromised, are at risk of reactivation. We'd also maintain the patient's platelets above 20 and the HB above 80, and the CRS and ICANS assessments, which are found on Nerve Centre, are completed 3 times a day. However, with these patients having 4-hourly observations, the ward nurses tend to do the CRS 4-hourly as well. As you can see on the right-hand side, that's just an example of the CRS assessment that can be found on Nerve Centre. So next we're going to look at the side effects and complications. So cytokine release syndrome and immune effector cell-associated neurotoxicity are the 2 that we'd be looking at closely for as the patients and inpatients. So the patients at risk of these within the first sort of 2 weeks. And with the ICANS, it can have a later effect, as we've said. Adverse reactions, so with the preservative, the patient's cells have been frozen in, tumor lysis syndrome, cytopenias, infections, and hypogammaglobulinemia and B-cell dysplasia. So as well as the CAR T cells attacking the cancerous B cells, they will also target and destroy the healthy B cells, resulting in the patient having low antibody levels. So therefore, it places the patient at a higher risk of infection. We can see with these patients reoccurring chest infections. So if the patient has had 2 or more infections, we would be considering immunoglobulin replacement for these patients. So next we're going to look at cytokine release syndrome. Sometimes we can hear it be referred to as cytokine storm. So it's when small proteins that are important in cell signalling are rapidly released into the blood from the immune cells. The T cells release the cytokines, which are chemical messengers that help to direct the immune response. The infused T cells will flood the bloodstream with cytokines. Typical side effects that we see include temperatures, low blood pressure, low oxygen, and it varies in severity. Ironically, CRS is considered a non-target effect of CAR-T, as its presence can demonstrate that the T cells are at work in the body. Patients with a high disease burden are more likely to experience more severe CRS, and CRS develops within the first week typically, usually day 2 to day 3. However, some patients we've noticed it can be the following day. So it does vary between patients, and it's important to reiterate CRS can be fatal. Symptoms that we see, there's quite a wide range of symptoms, ranging from mild flu-like symptoms to more severe and life-threatening. So the life-threatening can account for 10 to 15% of patients. This is the grading tool that we use for CRS. So as you can see, from grade 1, the patient has spiked a temperature, but otherwise they're fine. Grade 2, the patient can have a temperature, but we may also notice their blood pressure's dipped. They may have new oxygen requirements. However, we can manage the patient fine on the ward. Grade 3 is where the patient would be transferred to critical care because the patient could have a temperature, but also may be requiring a vasopressor, and they could be on a non-rebreathe mask. Grade 4, this is the severely unwell patient. So again, they could still have a temperature. They may be on multiple vasopressors at this point, and they may be intubated. So with grade 1 CRS, we'd be informing the doctors immediately of the temperature, as we'd be wanting to start the patient on antibiotics and following the sepsis protocol. Out of hours, again with grade 1 and above, we would be informing the haematology registrar on call. We can also speak to Hospital 24. However, with CAR-T being a fairly new treatment, I would advise going directly to the haematology registrar. So this is a quick guide that's been designed from our SOP. Every patient that has CAR-T, the quick guides for both CRS and ICANS can be found in the patient's nursing notes. So if the patient's presenting with grade 1 CRS, the first thing we would do, we'd monitor the patient, we'd cover with antibiotics and follow the sepsis pathway. If they've got a persistent temperature, we would consider the use of tocilizumab. So if the temperature is going above 24 hours, we would give tocilizumab. Occasionally, the medical team may decide to give it sooner than the 24 hours, but as long as the patient's had a senior review by a haematology registrar or consultant, and it's documented for tocilizumab, we can give the tocilizumab. Grade 2, we would go straight to the tocilizumab. Each patient has up to 4 doses that we can give them. So it can be given every 8 hours if needed, not exceeding 3 doses within a 24-hour time frame. So yeah, grade 2, go straight for your tocilizumab. We can consider steroids if it's persisting over 24 hours. We can also consider anakinra, which has a similar effect to the tocilizumab. Grade 3, if there's enough of the tocilizumab to continue, we can still give tocilizumab. However, we would be giving the dexamethasone alongside it. So 10 milligrams IV, 6 hourly, and again, we can consider anakinra. And grade 4, as I've said, we can continue the tocilizumab if there's enough doses to. However, we would swap the dexamethasone to methylprednisolone, 1 gram a day IV for 3 days. We can also consider continuing anakinra or increasing the dose. So tocilizumab, it's a monoclonal antibody. It's responsible for lowering the body's immune response and reducing inflammation. Saying that, patients who have received tocilizumab, if we are testing the CRP, we can get false readings because the patient's had tocilizumab for several weeks. So it's not always a reliable source to use for infection markers. Next, we're going to look at immune effector cell-associated neurotoxicity syndrome, otherwise known as ICANS, or neurotoxicity. So we believe it's as an effect of neurotoxicity post-CAR-T of the cytokines crossing the blood-brain barrier. It often accompanies CRS, however, it can occur independent to it. So if we're saying typically CRS can occur sort of day 2 to day 3, however, this does vary, ICANS can occur day 5 to day 6, but anywhere between that 8-week time frame, there's a risk. It typically manifests as a toxic encephalopathy, so early signs can include diminished attention, language disturbance, and impaired handwriting. The handwriting is one of the first signs that we see with these patients. Other symptoms can include confusion, disorientation, agitation, unable to communicate, even mutism, drowsiness, and tremors. Severe cases, so above grade 2, can result in seizures, motor weakness, incontinence, slow response, increased intracranial pressure, and swelling of the optic disc and cerebral edema. Risk factors can include pre-existing neurological and medical comorbidities and high disease burden, also early and severe CRS. And as we've said, there can be a late onset for up to 8 weeks. So the grading for ICANS, it's a 10-point assessment tool that we complete 3 times a day. We do, as long as the patient is stable and we don't have concerns, we do try and avoid completing the assessments overnight. So we try and make the last assessment around 10 o'clock at night and the next one 6 a.m. just so that if we are disturbing the patients and asking for a handwriting test, we may be getting a false reading. We don't want to give dexamethasone as treatment unnecessarily. So the questions that we ask are questions that the patient would usually know the answer to. So what year is it? What month is it? What city are we in? What hospital are we in? Can they follow instructions? So can they hold 2 fingers up and blob the tongue out, for instance? Can they name 3 objects? So can they name mobile? Can they name 3 objects? And each object is a point. Can they write their standard sentence? So they'll pick a sentence, we advise short but sweet, so I love my family, for instance. And it has to be the same sentence every time so that we can easily notice if there's a change there. All the patient needs to do is get one of these questions wrong and they're automatically a grade 1. As you can see from the picture on the right, a patient wrote their sentence, I love my family, on day 3. Day 4, there's an obvious change there. They've gone on to receive tocilizumab, and after 2 hours, there's already an improvement. By day 5, the patient is back to their normal. So we're going to have a look at the quick guide for ICANS. So there'll be certain investigations at each grade that we need to consider. So from grade 1, we would be seeking input from neurology. We'd be increasing the frequency of the assessments and starting neuro observations 4 hourly. We'd also be considering the urgency of a CT head MRI brain. The interventions at this stage, we would increase the Keppra, so going from 500 milligrams BD to a gram BD. We could also consider dexamethasone if the grade 1's persisting over 48 hours. And if it is alongside CRS, we could consider tocilizumab. Grade 2, we'd be informing the critical care and CCOT team as well as neurology. So again, considering what investigations may be needed, arranging imaging if this has not already been done, consider a lumbar puncture, consider an EEG. So if it's concurrent with CRS, we could give tocilizumab, We can consider anakinra as well at this stage. If it's not concurrent, ICANS without CRS, we would go straight to dexamethasone, 10 milligrams IV 6 hourly. And again, we can consider anakinra. If no improvement within 24 hours, we would manage as a grade 3. So grade 3 ICANS, these patients would be cared for on critical care. So again, what investigations do we need? We would manage as grade 2. Does the patient need an urgent EEG? Repeat neuroimaging if it's been greater than 72 hours since their last. If it's concurrent with CRS, we could continue tocilizumab and steroids and anakinra. If it's not concurrent, we would go straight for the dexamethasone again. We'd also be considering whether we need to make any changes to their anti-epileptic medications. Grade 4, we would complete investigations as per grade 3. The only difference we would do, if it's concurrent, we could continue with the tocilizumab if we've got that there to use. But the only thing different would be to swap the dexamethasone to the methylprednisolone. So as you can see, with the CRS and the ICANS, it's very, very similar management. So you'd start with your tocilizumab if CRS and ICANS are present, or if it's the CRS alone. If it's ICANS alone, go to steroids. But yeah, we've got tocilizumab, dexamethasone, anakinra, and methylprednisolone. They're the main treatments that we would use. And that's it in a whistle-stop tour. So thank you.
Thank you so much, Kat, for giving us a further insight into CAR-T. That was really helpful. And I'm hoping my colleagues will benefit from it, and I'm sure they will. I've learnt loads from that. So thank you again, and thank you for joining us for another session of Bridging the Gap. I hope you can join us on our next session. Thank you. Bye.
Thank you. Bye.